Hello and welcome to this King's Fund online event looking at the role of partnership working in transforming care for people with long-term conditions. I'm Ruth Robertson. I'm a Senior Fellow in Health Policy at the King's Fund and I'm going to be chairing the event today. I'd like to start the session by thanking AbbVie. They're one of the King's Fund's corporate partners and they're also the sponsor for this event. We have a great panel of speakers today representing a whole range of perspectives: a patient perspective, NHS England and improvement, ICS, industry, and the clinical front line. And I know that many of our speakers actually wear multiple hats, have been clinicians in the past, for example, or are patients with long-term conditions themselves. I'm not going to introduce each person individually because the best information about who they are can be found in their speaker biographies. So please check those out if you haven't already. You should be able to access them just below the video. So do have a look and find out about the wealth of experience they bring to today's discussion. I should also say we have a really great audience for this event. We checked just before coming on live and 1,200 people have signed up so far. I've looked at the attendee list. I wanted to be able to say we had the A to Z of participant organisations, but actually I think it's the A to Y from Active Devon to York Teaching Hospitals, and a real range of audience members from across different sectors, all sorts of different organisations involved in supporting people with long-term conditions. So I'm really looking forward to a rich discussion and a wide range of questions today. So let me talk a bit more about questions. This online event is live, so please submit your questions for our panel throughout using Slido. You should be able to see a box to the right of the video, which is where you can submit your questions and you can upvote questions that others have asked. So take a look, see which questions you're most interested in and give them a thumbs up. We'll aim to answer as many of the popular questions as we can during the session. We're also going to be putting up some poll questions and word clouds, which will flash up at various times during the session. So please look out for those in the Slido box and do take part. And I'd also like to encourage you to follow the conversation on Twitter. We're using the hashtag KFOnline. So for those of you who are tweeters, get onto Twitter and share your thoughts using that hashtag. We also recommend you take a look at the resource page. There's loads of great stuff on there, including a really interesting video about transformation of care for people with long-term conditions and elective recovery, all sorts of other resources. You'll be automatically directed there at the end of the session. So a chance there for you to follow up on some links and continue your learning on this topic. Basically, there are lots of different ways to engage in the conversation and learn more. So get your multitasking hats on, or just focus on one channel if that's the way you prefer to work. So I think those are all of my housekeeping points for the beginning of the session. And I think it would make sense for us to get started and hear from our panel. So while you start to submit your questions, and I can see that there are already questions coming up on the Slido, I'd like to take the chair's prerogative and ask some of my own questions to the panel to get things started. I think the place I'd like to start, it feels really important at the beginning of the session to set out why we think this topic matters. I'd like to ask the panel what they think the issues are for people with long-term conditions. Why do we need transformation for this group? You know, the NHS has got so many competing priorities at the moment. Why should transformation and care for people with long-term conditions be prioritised? And I'd really like to start by talking to Wendy. You're someone who has been managing multiple long-term conditions for many years. You're the person that these changes and this transformation we're talking about is likely to affect. So can you share some of your thoughts on why does this topic matter?
Well, thank you, Ruth. Yes, I'm happy to share my personal experience of what happened during the pandemic. However, I don't know whether I am truly representative of all the many, many patients with long-term conditions, because I'm very privileged that I've got a warm home, I've got good food, I've got a car that can get me to hospital appointments and to pick up prescriptions. And I've worked in the NHS, so I know how to navigate the system, as it were. And even if I didn't know how to navigate it after being retired for 10 years, I now know that I will be brave enough to ring up and try and find out. So that's where I'm starting from. But the pandemic has been really hard. Things are getting better, but I remember at the very beginning, the fear that I felt about living alone. What would happen if I got COVID? Would I ever see my family again? And it was quite a frightening experience. Yeah, even something simple like how I went from a regular blood test was a difficult one. The surgery didn't know what to do, whether I could safely come down. I was on the shielding list, and I think that also added to the anxiety. And so simple things like going for your grocery shopping or picking up a prescription was considered a dangerous activity. So I ended up with online shopping, which was fine. And friends picked up prescriptions. But I think because of that, I'm now finding it quite hard to live a normal life, doing normal things. I actually went into a supermarket the other day and felt myself suddenly have a panic when somebody came near me and rushed out. So yeah, it's going to be, I think, a long time before people with long-term conditions find the services come back to how they used to be and feel more confident in staying well and managing their condition. So that is my starter for setting the scene here.
Thank you so much, Wendy. And I think that just really hits home to us how people managing long-term conditions during the pandemic have been having to balance the risks and making quite difficult decisions about what they will and won't do. And real question for us today is how the healthcare system and its partners can work together to try and support you and make that experience of managing those risks and getting the best outcomes as easy as possible. I'd really like to hear from Johnson now, who's a clinician and ophthalmologist who's been working with patients throughout the pandemic and for many years before. Johnson, do you want to react to what you've heard from Wendy and answer this question of why this topic matters, just to set our minds on the right track at the beginning of this session?
Yes, absolutely. Thank you, Ruth. And thank you, Wendy. I think many of my patients, certainly from my personal encounter, will echo your experience. I think lots of people have the fear about when this pandemic is coming to an end and what the repercussions of the pandemic has on our healthcare services and when that's all going to come back to normal. I'm afraid, from a clinician point of view, I think the backlog of patients with long-term conditions is undeniable. And whether or not our healthcare services will go back to what it was pre-pandemic is entirely questionable. But I think we shouldn't focus too much on the unknown, but rather looking at what we can do to make a difference. And I think, time and time again, I think we all who are involved in patients' care needs to be reminded on what some of these effects of long-term conditions can have on individuals' mental and physical health, and whether or not they can be devastating and they can be permanent. So I'll just quote some examples in ophthalmology. For example, the common conditions like glaucoma or macular degenerations or diabetic eye disease. Now, these are some of the conditions that requires effective screening at the first place to pick up the condition, a very prompt referral to the hospital, and a very timely treatment by the clinicians. Now, we know that COVID has had an impact on all of these stages, meaning that the screening has been deferred, the referral has been delayed, and therefore the treatment has been affected. So it is when we look into things, and I urge all organizations as well as everyone within the healthcare system to really consider things in such perspective. It is when we think things in such perspective that we get reminded over and over again that some things have to change, some innovations have to take place, and that status quo is not going to be enough for us to cope with the demand that is coming post pandemic.
Thank you so much, Johnson. And just before we move on from this introduction, I'd like to come to Amy, who's working at a system level in North London. Amy, why does this topic matter from your perspective?
Thanks. So I think it's really important to call out the fact that right through the pandemic, health services have made a heroic effort to try and keep going with long-term conditions care under really difficult circumstances. And so it's easy to overlook how much people managed to continue to achieve during that period. So I just want to kind of acknowledge that. But even still, notwithstanding all of that, there have inevitably been some real challenges around trying to keep that golden thread of long-term conditions care going fully during the pandemic, and particularly around areas like Johnson was calling out around detection. So we will have people in the system who haven't had opportunity to have the screening or the detection services that would normally be available. And so we need to be really focused on trying to proactively find people to make sure our population is properly known. I think also, in many ways, what we want to be doing going forward around long-term conditions isn't necessarily new. A lot of this is about making sure that the really good practice around long-term conditions gets to continue going forward. But we've learned a lot also during the pandemic about bringing more care nearer to people and relying on people's assets and strengths in order to be able to keep going. And I think that gives us a really interesting insight and foundation to build on. How do we start to weave that into our approach to long-term conditions going forward? We build on people's strengths, we bring more care into people's homes, we create that context where we're really wrapping all the different elements of care around people in a very personalized way. And like we've learned through the vaccination program, we're really targeting communities, building on our knowledge about what matters to people, and proactively targeting health inequalities. So I think there's a huge amount to build on, but a huge amount to do going forward.
Thank you, Amy, and so many useful points there. I think it's always so important for us to remember the unmet demand and the need for case finding in this area, and to not just focus on innovating for those people already in the system. I was just reading a report from Carnell Farrar this morning that was talking about the huge numbers of people who aren't accessing care at the moment for long-term conditions who need it, and how can these partnerships come together to help us find those people. So let's move on to think a little bit about the positives. I know sometimes in these areas we focus on what's not working, the services people aren't getting, but actually part of the focus of this discussion is transformation. And I want us to think a little bit, before we move on to talk in detail about partnership working. I can see a lot of questions coming up in the Slido that I'll bring in about that in a second. Can we just talk about where the biggest opportunities are to innovate in the support of people with long-term conditions? What's the exciting stuff, and how do we make this happen? And I'd like to turn firstly to Lindsay, who's working at NHS England and Improvement on innovation. Lindsay, over to you.
Thank you, Ruth, and thank you to everybody else who's joined today. So interesting to hear Jonathan talk about the kind of the pathway and the clinical pathway and the opportunities to do things differently. At a national level, in the Innovation Research and Life Sciences Group at NHS England and Improvement, we're really wanting to think about what we can do in offering innovation and research as a solution to some of the issues that are the challenges we're facing post-pandemic. And you'll have seen recently in the press, there's been a couple of really high profile announcements around the work that we've been doing across the system to try and look at how we can bring disruptive innovation into the NHS that will really change pathways and also really start to address some of the really significant challenges. So just a couple of examples, you may have seen the deal on inclisiran, which will support it's a new cholesterol reducing drug, and starting to think about that kind of CVD pathway and how we can support patients to self-care more with that, and also the new GRAIL potential early cancer diagnostic. So really addressing some of the challenges that we've got now that we thinking about detection of diseases, colleagues have just said. You may think, well, how are we going to do that? And I think fundamental to the work that we're doing nationally is looking at what we call both demand signalling and horizon scanning. So demand signalling is really trying to understand actually where is that unmet need and what can we do differently, and how do we do that differently? And to answer that question, we use our horizon scanning program, which actually looks out across, we work with, I should say, the National Institute for Health Research Innovation Observatory, and they can scan across databases, registries, looking for new potential treatments that will really address those areas of unmet need. And we're really placing that as fundamental to the work at NHS England and Improvement at the moment. I think one more thing to say about the opportunities for innovation is really thinking about that kind of frontline culture of innovation in the NHS. And we're working really closely with CQC on thinking about how innovation is embedded in inspection routines as well as research, I should say. And we have a number of programs that actually support frontline NHS staff to be entrepreneurial and to really gain skills and expertise in bringing innovation into frontline services. So there's a number of things that we're doing across the piece nationally, but I should also say we've got a number of programs that support at regional and local level, and people on the call I'm sure will have heard of our academic health science networks, 15 organisations within England that actually work with local systems looking at their priorities and local needs to make sure that we're addressing that as well as thinking about it from a national perspective.
Thanks, Lindsay. And again, lots of interesting points there, and a new term for me to learn on demand signalling. It's also so interesting to think about how regulation might be used to support innovation, and perhaps people in the audience will have questions and thoughts and views on that. But let me now turn to Todd, who's representing industry today. And I'd really like to hear your views, Todd, on innovation and how we make this happen.
Absolutely. Thanks very much, Ruth. Yeah, I think for me, it's been a fascinating time to be working in the pharmaceutical industry. Certainly, we've taken an incredible amount of learnings and insights from the COVID pandemic. For one, I never thought I'd know this much about supply chain, but I can tell you we've done an incredible amount of work on supply chain, and our supply chain is certainly much stronger than it was previously. But from an insights perspective, obviously we're working with partners in the healthcare service all the time. And as we look at our medicines, I think that this experience has really started to push us to look beyond or to broaden, I would say, the value of our medicines beyond just safety and efficacy to how the delivery and how the services that we can build around the delivery reduce the burden on the NHS. This is a new value that we probably hadn't recognized as much before as we do now. So we have a lot of work going on across the industry and at AbbVie itself to look at these types of innovations to broaden out the value. And then I think I'm probably speaking for all of the companies in the pharmaceutical industry, but certainly at AbbVie, we really do feel as though we have a significant responsibility to patients here in the UK to try to reduce the backlog for patients suffering with long-term illnesses. And so we are working at the clinic level at the moment with doctors like Johnson, who's on the call today, to look for ways that we can take insights in order to come up with innovations to try to reduce that backlog. So there's a number of different ways that we're trying to work across the healthcare system, always trying to support the innovation that's ongoing.
It's so interesting hearing you speak about innovation there, Todd, and how much actually it's not just those scientific ideas and that kind of technological advancements that are important. Threaded throughout what you were talking about there with the partnerships that you have to kind of implement with clinicians and the NHS as a system and patients to really make this happen. Johnson, would you like to come in as the clinician or one of the clinicians on our call?
Yes, absolutely. Thank you, Ruth. And thanks to Lindsay and Todd. Now, I just like to introduce a dimension of digital transformation of care. And again, because of my background as an ophthalmic surgeon, I really like to use ophthalmology as a case example to highlight how digital transformation has taken place and has really, really been impactful in terms of transforming the way we look after our patients post-pandemic. So I think COVID-19, when it struck, all of us who care for patients were really pleasantly surprised on how quickly organizations and industries actually could adapt to such adverse situation. And suddenly everything was pushing towards using digital care, even the way we deliver today's discussion over a digital platform. So within ophthalmology itself, I think there was a very strong sense that we need to empower patients to also have their role in terms of looking after their own health, even though they've got long-term conditions. So at Moorfields, one of the examples would be a smartphone application called the All Eye app. Now, this is a app that's developed with the NHS Act, which is a unit, joint unit between Department of Health and Social Care, NHS England and Improvement to really drive digital innovation in the field of medicine. So with the All Eye app, this really is an app for both detection as well as monitoring of macular diseases. And we know that there are very specific symptoms, and without going into too much details, but patients can really sense themselves when something isn't quite right. So most of the patients who have macular conditions, they will be stable, and it is a long-term chronic condition. But when it hits, when they really do need input from clinicians, that is when they would notice huge deterioration of their vision, very stark distortion of their visions. And we think that patients are actually in the best position to report such symptoms. And if we can make that easier and we can take that setting from the hospital back to the comfort of their own home, and that would work. And actually the All Eye app has been a huge success. And it just shows what kind of changes we can make to the care for patients with long-term conditions if we do empower them and give them a chance to participate. Now, there is also a general move in the whole field of medicine about better connectivity between primary care and hospital. So we're really trying to improve the referral system from primary care as well as within the community to the hospital. And I'm really pleased to say that really, for instance, in ophthalmology, so much so that the referral system has advanced to the extent that actually, if you attend your community optician or you attend a general ophthalmologist in a district general hospital, and you do have a particular condition that requires a subspecialist input from a tertiary center, that can be done electronically. So that saves patient having to attend a tertiary center. It reduces the duplication of appointments. It shortens the time between referral and treatment, and then free up resources where we can see more patients, provide more treatment, and invest our time and resources into looking after these patients with long-term conditions. Now, one of the key innovation is also about virtual clinics. I think the concept of having a virtual clinic is not too foreign to many people because it has taken place pre-pandemic, but really has shown its value during the pandemic. Now, we are looking, virtual clinic means that patient attends a particular clinical setting just to have the diagnostic data collected, and then they go home. and the clinicians would then review this data and make a decision. Now, this in ophthalmology can be seen in long-term conditions such as keratoconus, and again, glaucoma, and again, macular conditions, where this data can be collected and the clinicians can spend more time reviewing more cases, and in turn, becoming a more cost-effective exercise where we can improve patients' care. Now, then people have questions about whether or not this is safe, whether or not this is effective. And we actually have data from the National Outpatient Transformation Program for ophthalmology in specific to show that this actually improves patient care, because right now there is shorter wait to be seen by clinicians, and we can react more promptly to the diagnostic data that's been collected. And I think, as we speak, I'm very pleased to say that all 7 NHS and improvement regions are already in the process, if not have already secured the electronic eye care referral system for their local eye care services. That means that there is a general interest and general motivation from all NHS England and improvement regions in adopting such referral system. And I think that's great news to hear, because that shows that everyone is within the same page. They embrace the technology and they embrace some form of innovation that actually is really going to work.
Brilliant, thank you, Johnson. It's really great to have those tangible examples of innovation to get us really thinking at a granular level about this topic. I'm just looking at all of the questions that are starting to come up on Slido, and it's great to see all of the engagement from the audience there. So thank you to all of you for the questions you're submitting. There are some really popular questions up at the top here around partnership working and breaking down barriers. How do we get people to work together to get this innovation agenda off the ground? Particularly, how do we break down some of those barriers between the NHS and the voluntary sector? How do we bring industry in? There's a question here that there are tremendous resources in terms of people, knowledge and skills, but reluctance from NHS leaders to engage properly with industry. There's a question pointing out that there are some quite big barriers to the voluntary sector and the NHS working together. Some of these, I'm sure, would also apply to industry, including information governance, if anyone's trying to interpret the IG acronym on that question, procurement contract limitations. So I'm going to just ask some of the panel members to respond on that. And I think it makes most sense, perhaps, Amy, I will in a minute come to you from the ICS perspective. If you had any thoughts about, how do we break down those barriers, bring in all those different partners and make partnership working happen? And what's your role at the ICS in kind of getting this all off the ground? So just a simple question for you to answer there.
Nothing complicated at all. Yeah, thanks. No, it's been really interesting listening to the conversation and thinking more and more about this. And I think one of the things that we're seeing in our system is that, first of all, there's a few really big enablers. So we've got a fantastic integrated health and care record in North Central London and a population health management platform that's allowing us to start to develop really meaningful ways for us to break down some of the sectoral boundaries and barriers that have perhaps historically prevented us from working in a much more coordinated way. So in the end, I think what we're trying to create is a culture of mutual accountability for the health of our population, which means that anyone who comes into contact with someone feels both empowered and accountable for trying to improve their health. So having a shared record where we can all see the same information that we've all contributed to is a really critical part of creating that different kind of culture and environment. And we know that with long-term conditions, the lived reality for most people is more than one. So people are living with, in a context of multi-morbidity, they're trying to grapple with a number of different problems concurrently. Some of those will be very obviously health related, but there are biopsychosocial dimensions that people are living with every day. And so creating partnerships and collaborations that allow us to reflect that lived reality more meaningfully has got to be our kind of central focus. And from the ICS perspective, part of that is about trying to create the context that allows those partnerships to flourish. So understanding what the practical enablers are to make that happen. And the information governance is one example of that. Some of the clinical governance and accountability questions are very strongly related to that. We see that in the kind of the evolution of remote monitoring and virtual wards. You know, how do we create the right context and break down some of those barriers and overcome some of the obstacles? And I think the more we're able to create frontline teams that cut across boundaries and are able to build relationships, have the connections and empathy for the context in which one another are working, and mobilize all the different skills and expertise, perspective, and opportunities that come from those collaborations, the more we'll be able to create an environment that wraps around people and allows them to play the central role in terms of, as I said earlier, and we'll go on about, is building from people's assets, building from people's strengths, rather than a kind of deficit approach, which is maybe historically where a lot of us have come from, but moving into this new space. And those partnerships should help us create that context collectively where we're mutually accountable to support and strengthen people's own ability to manage their conditions.
Brilliant, thank you, Amy. And now perhaps I could bring in Lindsay, from looking from NHS England and improvement from that national perspective. What's your role in supporting systems in this mission and this task?
Well, thank you, Ruth. Just picking up really on the comments and questions that you were getting around kind of barriers within the system, and also thinking about how things will play out with the new structures with ICSs. Just wanted to reassure people that there's a lot of work going on at a national level to ensure that research and innovation is embedded in frameworks for the new ICSs, but also in senior leadership job descriptions to make sure that people are accountable and have a responsibility for ensuring that research and innovation is embedded and adoption of innovation is a high priority. We also, as I mentioned earlier, have our academic health science networks who are reaching out across the regional and local systems to offer their support in terms of making sure that they are helping with those local priorities as I identified. And there's a number of areas where the AHSNs and also other research organisations are supporting ICSs to actually embed research and innovation. So it's a work in progress, but it is happening at both a national and local level.
Thanks, Lindsay. And I'd just like to pick up on another point that Amy made, talking from the ICS perspective, about how important it is to develop these frontline teams that cross boundaries, and that these are the people that are really kind of doing the face-to-face implementation of a lot of this stuff. I'm interested to bring Johnson in as our frontline representative here. Have you had any reflections on the importance of the workforce and the way it's structured and made up, and the challenge that Amy described there?
Absolutely. So I think the whole idea of workforce planning can be an enabler, but can also be an inhibitor when we talk about how we want to push forward better care for patients with long-term conditions. And I just like to sort of draw an example. For example, I talk about digital transformation. So we need to think about, say, for example, now there is a digital innovation that we're ready to go. We've done a trial about it. We know it's effective and it's going to work. And it's all about upskilling that from 500 trial patients to tens of thousands of patients within the organization. And now within this context, it is not just about deploying new technologies and monitoring this data. It is about getting the entire workforce to be ready to embrace such technologies, to be able to embrace and adapt to what's going to happen when such innovations take place. And that really requires, and that echoes what Amy had mentioned, as well as what Lindsay had talked about leadership. That really requires very strong and firm support from the leadership team across organizations to make sure that the frontline workers and the workforce is ready for it. And for instance, in Morpheus, there is a significant investment in setting up this Department of Digital Medicine, just to echo the example of digital transformation I talked about. So this department was set up because we recognize that there is a need for a central entity within the organization itself to look at information governance, to look at patient safety, to look at whether or not this makes clinical sound decisions from the level of innovations that come in. So I think those support from the leadership team within organization is crucial in preparing the workforce. Now this also, I mean, I'm just gonna put on the thinking hat of my other role as a population health fellow based at the King's Fund. I just like to draw a quick perspective into what we think and what we perceive as a population health system that will work, which means the patients with long-term conditions will be well looked after. So the 4 pillars that we're thinking here, number 1 would be wider determinants of health. So whether or not patients getting the transport they need, they have the employment, education necessary. And then the second bit will be the health behaviors and the lifestyles, whether or not they is there any way we can modify some of these modifiable risk factors, such as smoking, alcohol intake? And then there is places and community where the ICS really comes into place. And more importantly, integrated health and care system. Now, we know that there is a growing number, and it's undeniable that there is a growing number of patients with multiple long-term condition and not just one long-term condition. And there is a need to integrate the health and care services around their needs rather than organization silo. So once again, how can we go about planning these health and care services around patients' needs rather than individual organizations? And that again requires very strong leadership and very strong political will within organizations itself. So those are just what I really think would need to be at the back of someone's.
Thanks, Johnson, and also thanks for that clearly setting out as a reminder to us that this partnership task goes well beyond the NHS and you know, requires a population health approach that covers all of the different aspects that affect people's lives. So actually, before I come to Wendy, who I'm going to ask a bit about her life and what good looks like for her, I first want to just come back to a question we mentioned earlier about industry and how we really make the most of the kind of offer there from industry. You know, there's been strong partnership during the pandemic, and I think there's a desire on all sides to sort of continue effective partnerships as we hopefully emerge from the pandemic. So Todd, any thoughts from you about how we develop those partnerships more and make the most of the kind of coming together of those skills?
Yeah, I think from an industry perspective, you know, every successful collaboration that I've ever been involved in my career has started with an insight from either the clinician or from the patient, and the ability to work quickly at the clinic level to design a solution that can then be scaled up. So I was very interested in hearing from Johnson about, you know, how he's taken the project through the scaling effort, which is a huge effort. But you know, I'm representing a pharmaceutical company. There's a number of other industries, obviously, that serve the health service, and so I think, from a pharmaceutical perspective, we've got a role to play in terms of understanding where the need is, really listening to where the gap is in the care delivery, working at the local level to try to come up and to ideate, bringing in partners where we need to in order to come to the best solution, and then trying to work to make sure that these new innovations get scaled. I think my ask today is the same way that the National Health Service and the Department of Health brought us in as an industry to try to solve the acute pandemic issues, I'd like to think that we could still be the same level of partner at the table as we come out of the acute period and deal with some of the challenges that the pandemic is causing us here in the longer term. So, I guess from an industry perspective, we have a lot of skills, a lot of capabilities, and resources to throw at this problem, but we need to be at the table in order to do it.
Yes, brilliant. Thank you, Todd. And one of the kind of key points you made there was about listening and taking what you hear as the kind of initial stimulus for innovations to patients and clinicians. So let me pass over to Wendy now. I'd like to hear from you what good looks like from your perspective as a patient, and what would make a difference for you in terms of transformation. What should people be aiming for with this collaboration we've been talking about?
Well, it would be really good if people looked at you as the whole person, not just health seems to be organised around one condition. And it would be really good if somebody looked at all the different conditions you had and tried to have a package that looked at those 3 different things or 4 different things together, not separately. Because I can't begin to tell you how many unnecessary x-rays and blood tests and hospital appointments I've had over the years, because it was all done as, this is for your rheumatology, this is for your diabetes, this is, So I would like to see some joined up thinking for patients to avoid all this waste, really. I think there's a lot to be learned from listening to people like myself. And I think people are beginning to talk to patients and hear from them. And I know lots of the charities are doing lots of work, and the Richmond Group, about what happens, examples of good examples and bad examples across the country of local services, and in deprived areas, in areas where there's lots of ethnic minorities, because they're all very different. And I think whatever new is in this transformation, as it were, has to be tested against all different situations.
Thank you so much, Wendy, and your response there is reflecting some of the points I'm seeing coming up on Slido around the need to look at the whole person, take a holistic approach. Yeah. And we'd hope that the partnerships we're describing really would see that as their goal. That has to be their one of their key goals, I think. I'd be interested, actually, I'm going to come to Amy now for the ICS perspective. I mean, firstly, I'm interested to hear about whether and how you're listening to patients as part of your work. But also, I'd like to bring in the topic of inequalities. It's come up in the questions, and it surely has to be a key goal when we're trying to innovate and transform care for people with long-term conditions, that we address some of those huge inequalities in access and outcomes for people with long-term conditions. A specific question has been raised in relation to digital and the opportunities there to, I guess, improve and exacerbate inequality. So interested in your reflections on those 2 points, how you listen to patients and your approach to addressing inequalities.
Okay, great. And I'm going to sneak in a 3rd point, if that's okay.
Go for it.
So in terms of health inequalities, it's such an important point. I'm really glad it's being raised in the chat, because we've got to be both mindful of ways of which we might be worsening health inequalities through some of the unintended consequences of our drive towards innovation. So some of those digital initiatives are really intended to be improving care, obviously, and improving empowerment. But for our population that's digitally excluded, we need to really be mindful of what the consequences of that could be, and we don't want to leave anyone behind. So we need to be always thinking about ways in which we need to be aware of and overcome some of that digital exclusion. And that's not simply by trying to increase digital inclusion in the most obvious way. It may be because some of the technology becomes less reliant on digital capabilities. And so it is inherently equitable in terms of access. So I think there's a lot for us to do around that. And the more we are kind of proactively looking at our population, particularly our long-term conditions population, and understanding how health inequalities are playing through, not just in terms of prevalence, but as you say, in terms of access and outcomes. I mean, we see in some of our data that sometimes health inequalities are less visible in once you're in the system, but it's getting people in the system in the first place. You know, it's the access question where we really need to be putting a lot of our energies. And I think in terms of listening to service users, to our residents, I think we really are making putting a lot of energy into moving outside of a kind of with a kind of more historical approach into a kind of co-production model, where we're spending lots more energy trying to start with our communities and build upwards in terms of what people really need, rather than how can we bring communities into the services that we're offering. How do we need to change the services to meet the needs of those communities, and really changing our orientation? And the ICS provides the perfect context for doing that, because if those local partnerships are working optimally, the voices through all of those different entry points into the system, including the community and voluntary sector, should be enriching how we approach co-production right across the board. And the last point I wanted to make was really in response to Wendy's point about being seen holistically. Is that I think we need to always guard against, and Muir Gray used to talk about this all the time, a specialism being a partialism. We need to always be trying to correct for that and make sure we're always coming back to seeing the whole person, and organizing services around the totality of need, and not letting specialism become partialism.
Thank you so much, Amy. And I want to bring Johnson in now. I don't know, Johnson, if there's, you've already talked about some digital innovations, but with your population health focus, I'm not sure if there's more you want to say about the challenge of addressing inequalities. And I also just wanted to bring in a couple of points from the chat. You were talking a lot about self-care, and someone's mentioned on Slido, self-care is not the same as supported self-management. I don't know if you want to react to that. And there's another question here about how important we think proactive rather than reactive care is when transforming care for people with long-term conditions. Over to you, Johnson.
Sure. Thank you, Ruth. I think, first of all, I'd just like to say that in order to truly achieve a whole sort of integrated care, especially from the lens of population health, where we look at the wider determinants of health for patients, including income, employment, education, transport, and their health behaviors, and how the community they lived in, or the place that they lived in, actually has an impact on their care, as well as an integrated health and care system around their needs. In order for all those four pillars to work, really there is a crucial bit, which is having a shared objectives by everyone. So who is involved in patients' care. So I think number one, it's that we with respect to planning interventions by organizations or sectors, we should always put health inequality as being one of the key focuses. And by doing so, then we can really cater the social needs of health on top of the medical need of health. And then we can truly see a patient as a whole. And with regards to the question about self-care, not being the same as self-management. I think that that's a really valid observation, supported self-management. I think that's a really valid observation. And it's about how we will be able to magnify those individual needs where they really require those support for them to feel empowered enough to be engaged in sort of health innovations that will propel them towards being able to look after their own long-term condition or being able to engage with health innovation. It is the question remains on how sectors could effectively capture this sort of needs in terms of support. I guess one of the ways that I could imagine from the lens of a population health fellow as well as a clinician will be to really target patient groups or population that we already know will be subjected to health inequalities. So we'll be looking at places that are already underfunded or particular risk groups or a particular population with a specific risk factors for particular long-term conditions or an aging population, for example, and all those are key indicators of where we could perhaps start by looking at whether or not support can be given for patients to feel empowered and to be able to engage with those health innovations. I think that would be a pragmatic first step.
Thanks so much, Johnson. I'm conscious we're in our last 10 minutes now, and I'm trying to fit in as many of your questions as possible. An interesting question here about personalised care and how we embed personalisation in the way we build back post-pandemic in a holistic and meaningful way to people. I'd like to open that up to the panel. Would any of the panel like to chip in response to that question about personalisation?
I'm happy to come in. I'd like to give a practical example of some work we're doing in North Central London that might bring this to life a little bit. So as part of the elective recovery initiative across our system, we've been, and we're one of the accelerator sites, one of the accelerator systems, we've been looking not only at what can be done within the secondary care context to try and address some of the waiting lists, but we've actually been looking at how primary care, things that happen outside of hospital can support elective recovery. And we've been establishing these new proactive integrated teams that are focusing on people who are waiting and to support them to wait well by using our population health management platform to proactively stratify and target individuals who have multiple long-term conditions, who have known health inequalities, to kind of cut and filter those data in as many different ways as we can, and bring together a rich mix of different expertise and specialism around the individual to proactively optimize their health and well-being, to provide personalized care and support planning, to make sure that that individual feels known by services and is being proactively offered support. And that can be health and well-being coaches, it can be social prescribing, it can be pharmacist input, lots and lots of different elements of care to wrap around that individual and help them optimize their health and well-being. Also to help for people with multiple morbidity who may have more than one referral. So they're waiting in for several different appointments, to try and bring that together and just to Wendy's point, try and prevent the duplication of effort, coordinate some of their appointments, reduce inefficiency and improve experience. And I think that's knitting together proactivity, personalization, and a kind of system-oriented approach where we're bringing some of our expertise in secondary care into primary care to work collaboratively to optimize people's health. And that breaks down the barriers, and I think is emblematic of how we're trying to create an equitable, integrated system going forward.
Thanks, Amy, and a brilliant kind of description there of what holistic personalised care looks like when working across boundaries and sectors. I'm conscious that we're actually coming towards the end of our time. We've got about 5 minutes left, and I'd like us to move on to a kind of final reflections part of the session. We hope that you, the audience, will go away and tell your teams and colleagues about this event and some interesting points that you took away from it. So I'd like to take this opportunity to go to each of our panel members in turn and ask them what one message you'd like people to be passing on in those conversations. Let's do a little bit of the thinking for people. What one message would you like people to take away from this event? And I think I'll start with Wendy. Let me come to you.
Well, I think my message is a bit simple, really. Whilst the NHS and the media are all focusing on COVID, pressures on GPs and in A&E departments and the backlog of treatments that are needed after the pandemic, I would say, please don't forget all the people, the many, many people with long-term conditions. I don't want them to become a low priority, because people with multiple conditions already have poorer health outcomes. So I think my message is, don't forget us.
Thank you, Wendy. Lindsay, let me turn to you.
Thank you, Ruth, and thank you, Wendy, for kind of bringing that into sharp focus. I think listening to the conversation today, my kind of take-home message for both myself and people on the webinar this afternoon is there's a huge amount of opportunity out there. There's a huge amount of opportunity to innovate. Partnership working is absolutely key, and going to Todd's point about making sure that industry remain a key partner at the table, I think it's absolutely vital for that. But I think there's also consideration in terms of this is not easy, and there are a number of barriers and equally a number of unintended consequences, and we just need to make sure that in that partnership the communities and the people who are accessing services are absolutely key and are driving the transformation with us.
Brilliant. Thank you, Lindsay. Todd, let me turn to you.
Yeah, I think from my side, we all recognize that there's a massive pressure on the system at the moment, but we should make sure that that doesn't stop us from collaborating. During the acute period of the pandemic, that collaboration was incredibly strong, and so it really does need to continue. And collaboration doesn't mean slowing us down. So I would kind of again reiterate this need for collaboration, this need to be holistic in terms of what we're trying to achieve for patients, which is a good key point that was made today. The need to make sure that all of the partners and stakeholders trying to deliver the best healthcare services for patients in the UK are brought together. And then lastly, I just think it's about setting ambition. We need to set the ambition high, because it's only when you set that ambition high that you can really achieve things. And so coming from the United States and being here in the UK during the pandemic period, I was incredibly impressed with the ambition that the NHS, that the Department of Health set, and largely achieved. And so I would just, again, continue to challenge all of us to set those high ambitions, because that's the way we're going to make real progress.
Thank you, Todd. Yes, let's aim high. And Johnson, over to you.
Yes, after listening to everyone's excellent discussion, I just want to reiterate that innovation is happening, transformation is happening, and collaboration is happening as well. But in the midst of all the innovation, collaboration, as well as transformation, I think we shouldn't lose sight on our focus, which is our patient, as well as the big matter of health inequality. So always having that at the back of the mind whenever we're planning some form of innovation or transformation. And really, the key here is also not just for patients to embrace such changes, but also for organizations and partners to be willing to embrace such change that we shouldn't just be working as a single entity, and those partnerships is just so crucial in getting these innovations to come to reality.
Brilliant, thank you, Johnson. And final panelist, Amy.
Gosh, there's not a lot to add to that really excellent contribution from everybody, but I guess bearing in mind where we are in the year and coming into winter, and all the challenges that may well lie ahead for health and care services, I think keeping that golden thread of proactivity going, remembering that populations are made up of individuals, and meeting people where they are in every encounter must be the way to serve ourselves well over the winter.
Brilliant, thank you, Amy. And we're dot on 2 o'clock, so all that's left is for me to really give so much thanks to our speakers for what I think has been a fascinating conversation, and hopefully people listening have found some ideas to inspire them and get them thinking a little bit differently about this challenge. Thank you also to the audience for all of your contributions and questions. I'm sorry I wasn't able to get through more of them. We'd like to encourage you to share a link to the event with colleagues, because you can register and watch back on demand. So do still feel that you can share it. And also just to mention to you that a feedback button will appear at the bottom of the page, and you can provide, we really value your feedback, just a short survey to help us continually improve our events. Do look at the resources page, all sorts of excellent things on there. As I mentioned, a video, links, other things to help you keep thinking on this subject. And a final thanks to our event sponsor, AbbVie. I'll let you go and get on with your day, but thank you for giving up an hour of your time for this really interesting discussion. Many thanks.